MD, PhD, etc. by Captain Dr. Robert N. McClay. Hi, and welcome back to the ongoing Introduction to Psychiatry series in the MD, PhD, etc. lecture series as a whole. If you missed the last session, this is on Introduction to Psychosis, and last time we covered the emergency diagnosis of psychosis, differentiating psychosis from delirium, from dementia, basically looking out for the things that medically can potentially kill you or require a medical intervention rather than an antipsychotic or psychiatric intervention. So I do recommend reviewing that if you've not seen it already. But presuming at this point that we have split that apart, someone's been, quote, medically cleared for psychiatry, and we now know that someone has persisting and consistent loss of reality, often in the form of hallucinations, delusions, altered perceptions, conceptualization, sometimes negative symptoms, that they have now been transferred to psychiatry, and we want to start to split them apart into different specific diagnoses. And that's going to get eventually to the biggie that we're most often looking at, which is schizophrenia. But our differential is going to be schizophrenia, bipolar disorder, schizoaffective disorder, major depressive disorder with psychotic features, delusional disorders, and a few other zebras that are in there as well. By zebras, we mean rare phenomenon from the old doctor's adage that when you hear hoof sounds or hoof beats, to think of horses, not zebras. So these are other rare things that, again, you don't need to worry about most of the time. But in doing all of this, again, you've got someone who's been fairly consistently psychotic. You don't think that this is life-threatening, but that does not mean that we have ruled out entirely causes of drugs and medical conditions. So this is why, if you look in the Diagnostic and Statistical Manual about psychosis, you will see specific categories that are still called psychosis, but psychosis due to a substance or psychosis due to a general medical condition. So, for example, you can have an acute delirium that is brought on, say, by PCP, but even after the drug has metabolized out of the system, it's no longer detectable. A patient still can have persistent psychotic symptoms that are actually caused by the drug. And sometimes when you've got multiple overlapping things, we may never be entirely able to rule this out. Just because someone was psychotic and had a positive PCP test, it does not mean that they don't also have some underlying occurring and remitting condition that's in here. So often this can be quite tricky to differentiate. But what is going to be the key component of this? And it's really going to be time. So presumably with drugs, they do eventually metabolize out of your system, usually in most cases within about 24 hours, which is why even for the basic psychotic spectrum disorders, the first sort of level that we'll talk about is what we call the brief psychotic disorder. That really only begins at 24 hours. That if a psychosis resolves in less than 24 hours, we're usually going to assume that it was caused by something else. Most common offender by far is going to be drugs. In the population that I see, that's probably methamphetamine, but definitely PCP, sometimes very high dose of marijuana, synthetic marijuanas, synthetic cannabinoids like spice can do this. Some other synthetic drugs like bath salts. We wrote a scientific journal article about discovering some of these in the military early on, because the military is a population in which people were trying to hide their drug use, so they were using things that they thought wouldn't show up on drug screens, and often with some very negative effects. And sometimes those did last longer, sometimes weeks or months, but the flip side is that most of the what we call primary psychotic disorders, the things that we're really going to consider treating with antipsychotic medications longer term, are going to last at least 24 hours. Now, let's say you do have symptoms in which we have a loss of reality testing in some way, shape, or form. Hallucinations, delusions, catatonic symptoms, in other words, somebody who is so impaired that they really just sort of lock up or get locked into repetitive motions where they're just sort of acting like an automaton to some extent, or prominent negative symptoms where they're not able to sort of engage and figure things out in the way that a regular person was. Or regular is the wrong term, without somebody without that mental disorder would be able to do. They can't seem to read, interpret normal signals. In reality, if you have this that lasts at least 24 hours, but less than a month, we have what's called a brief psychotic disorder. Now, that brief psychotic disorder may be explained by a number of other things, but it is the first step in the eventual diagnosis of a lifelong condition of schizophrenia. But there's also going to be other things that can happen. You can have symptoms that come and go, whereas with schizophrenia, what we're eventually looking to potentially diagnose is a condition that we presume means you're psychotic forever. Maybe not entirely forever. There's some evidence this can burn out in old age, maybe over the age of 65. Some of the symptoms remit, but basically a lifelong condition that's going to require lifelong and consistent treatment. So for that reason, we do not want to rush to this diagnosis. We want to make sure that we have observed this person for an extended period of time and they have these symptoms consistently without other explanations. So to get to a diagnosis of schizophrenia in general, we're going to require 2 symptoms of psychosis to be consistently present for 6 months. And we're going to have a different degree of certainty in terms of what this is as we go along. As I mentioned, at 24 hours, we start calling it a brief psychotic disorder between 24 hours and 1 month. And the thing is that often in that time frame, we may come up with other things that do explain the psychosis. Once you get to a month, though, that we start to get a much higher degree of certainty that this is eventually going to turn into schizophrenia, but we're not absolutely sure yet. And there we start calling it schizophreniform disorder. So if you again have at least of these two of these psychotic symptoms, or actually there is one other exception, by the way, where only one psychotic symptom is so defining of the illness that if it's present, we would consider this is likely along these levels of psychotic disorders. And that's if you hear 2 voices talking back and forth to each other. In general, the nature of the voices in schizophrenia is degrading, often enforcing paranoia, and often accompanied by these other negative symptoms where someone can't interpret, that their emotional range seems very limited in that regard. So if, again, at 1 day to 1 month, you have a brief psychotic disorder. Between 1 month and 6 months, we have schizophreniform disorder. And if we get all the way to 6 months with these symptoms just sort of being there being no other explanation, they're consistent, they're there all the time, then we finally have a diagnosis of schizophrenia, which we're basically saying this is not going to go away. You're going to need lifelong treatment, or at least treatment until, say, your 60s. On antipsychotic medications, or these things will come back. But what else, when you've got that brief psychotic episode, what other things could explain? So we've already said, there could be drugs, there could be other, say, medical conditions, which we talked about in the last session, that could explain things. But also there are other psychiatric diagnoses that we have to think about. And the big split is between bipolar disorder and schizophrenia. And a psychiatrist called Kraepelin, I'm not exactly sure on the original pronunciation, was the first to really sort of identify this, to realize that there were conditions in which psychosis seemed to come and go, and there were other ones where it stuck around, and that the one in which it came and go was almost invariably associated with emotional changes. Either an episode in which someone seems to have exceedingly elevated emotions, and that they're feeling sort of high, acting as if they're high, often feeling very euphoric, having super amounts of energy, not sleeping, looking sort of like Robin Williams does in a number of his routines. And that was psychosis as part of mania. Sometimes people think that mania is synonymous with psychosis, and it's not. Mania is an elevated mood state that goes along with other areas of impairment, and we'll talk about that in the lecture about bipolar disorder in and of itself if you haven't seen that. But bipolar disorder can come with psychotic features. It can look just as bad and be very hard to tell from schizophrenia. And this is why often you will see people in their medical record, if you look just through all their diagnoses, you'll see a diagnosis both of bipolar disorder and a diagnosis of schizophrenia. And patients will tell you, I have bipolar schizophrenia. And you can't, by definition, because the point of those two diagnoses is to split them apart. So you either have bipolar or you have schizophrenia. It's just that they're very hard to tell apart quite often in the psychotic phase. So, but eventually we're looking at whether this condition comes and goes or whether the symptoms stay around all the time. And again, specifically comes and goes, in that case, in the context of mood. And we think about it being bipolar disorder, in particular, if these psychotic symptoms occur during the highs, during the elevated manic phases. Now, in bipolar disorder, you could also have psychotic symptoms during the lows, but there are also people who never have the highs and only get psychosis during the low phases, and that's called major depressive disorder with psychotic features. Of note, there is some difference in the way that the psychosis usually presents in these different conditions. So in schizophrenia, we often think about the most common type as being paranoid schizophrenia. The hallucinations, the delusions are often quite paranoid. They're negative. The voices say derogatory things. They tell you not to trust the doctor, that people are following you, things like that. Whereas in the mood-related psychoses, what are also called the affective psychoses, affect is sort of the psychiatrist's read on what mood looks like, that the hallucinations and psychotic symptoms will often match the mood. So if someone's in a manic phase, they're very elevated, they may feel like God is talking to them and telling them that they're great and they're wonderful and they're special in this regard. It'll be often quite positive. Not always, because sometimes in mania a person can be quite irritable, and again those hallucinations and psychotic symptoms often match the mood. But then if you get into the major depressive disorder with psychotic features, the person is already very depressed, very low. The voices are often telling people very negative things, you're worthless, similar to schizophrenia in that way, but more of a sort of down and blue nature rather than so much fixated on the paranoia. Of concern, in particular major depressive disorder, but can also happen in schizophrenia, the voices may tell you to hurt yourself or to hurt other people. And those are very concerning. That is a symptom that nothing's always in psychiatry, but if it's genuine, it is something that usually requires hospitalization because people may well act on those. If they're already feeling depressed and they hear a voice telling them to do something all the time, particularly, by the way, if they recognize the voice, if they think that this is the lost brother or the devil, but they know who it is, people are more likely to act on the command hallucinations. So initially our split, again going back, is that we see somebody who's psychotic, they have persistent loss of reality, we're going to rule out drugs, we're going to rule out medical conditions, but then we're going to look in terms of primary psychiatry. Is this going to be bipolar disorder, or is this going to be schizophrenia? With bipolar disorder, they come and go, matching the mood. With schizophrenia, they are there all the time. And the reason this matters is less important than it used to be, because as we'll talk about in the treatment talk, modern antipsychotic or neuroleptic medications have both mood stabilizing and antipsychotic properties, so you can treat sort of both with the same medications. But it used to be very important because we had separate mood stabilizers. We still do. Lithium Depakote, which is carbamazepine, anti-seizure medication, are medications that stabilize mood over the time. And say with just straightforward depression, you can use any number of antidepressant medications. And if you can control the mood, if you can stop one of these ups and downs from occurring, you may not need antipsychotics. And the side effects of the antipsychotics are often viewed as being considerably worse than those of the mood stabilizing medications. So in theory, you may not need to be on antipsychotics all the time, versus with something that eventually turns into schizophrenia, that is someone who is going to really need to be on antipsychotics all the time, at least if they wish to maintain contact with reality. Now, I said you really can't have bipolar disorder and schizophrenia by definition, but there actually is a blended condition in which people will come in really looking exactly like bipolar disorder, classic manic episodes or classic major depressive disorder with psychotic features. But even in the absence of drugs, even in the absence of a medical condition that will explain this, at other times that they will come in without any of those mood symptoms and looking just like schizophrenia. And that sort of blended condition is called schizoaffective disorder. Supposedly, it is quite rare that really most people should have either schizophrenia or bipolar disorder who have a primary psychosis, but often, especially with drugs, people end up looking a lot like schizoaffective. So in severe mentally ill populations, you will see it labeled quite often as the diagnosis, because sometimes people have come in looking one way, sometimes people have come in looking another way, and we have to make our best guess as to what this is. Where it matters in the prognosis and what will happen to a patient is that schizophrenia is unfortunately one of the worst diagnoses that we can give people. Again, they're going to have a really change in who they are with this, and it's going to last essentially forever. Schizophrenia sometimes gets confused with the idea of multiple personality because the word means the splitting of the self. But what that means really is not multiple personalities. What it means is that the personality changes, that there is a total characterological change in someone with schizophrenia, and it really never seems to come back to normal. I once saw an episode of a show called Buffy the Vampire Slayer that talked about the way vampires worked, and was saying that when someone is bitten by a vampire, it's not really that they're still there, it's that this other demon soul has inhabited their body. It has their memories, it has their actions, it has their features, but it is an entirely different creature. And in some ways, schizophrenia may have been the inspiration for that, because in schizophrenia, the person is quite often different. Someone who was previously charming and pleasant and very loving seems incapable of those emotions, those connections. They act entirely in a different way. Now, some of that can come back with medication, but by itself, there is a lasting and seemingly permanent change. Whereas bipolar disorder, this really can come and go. There are plenty of people, famous, successful people with bipolar disorder. Again, I mentioned Robin Williams. I don't know about that one. He never was public about whether he did have that diagnosis, and he clearly was public about the fact that he abused cocaine, which can look a lot like bipolar disorder. But his mentor in all of this, Jonathan Winters, was very clear about the fact that he had bipolar disorder, but famous, successful comedian, and with, in a lot of ways, the same style of acting. Carrie Fisher, Princess Leia. People think that Handel, Bo's Messiah, obviously before we had formal diagnoses, but we think that he likely suffered from bipolar disorder. He talked about divine madness and demonic depressions that occurred around his composing music. It certainly sounded like bipolar disorder. But again, all of these people were very successful. Their conditions came and go, and during the interval between the ups and the downs, they're back to their regular selves. And even during the run-up to the mania, often are sometimes sort of hyper-productive, sometimes why people don't want to get their bipolar disorder treated before it gets all the way to psychosis, unfortunately. So again, better prognosis with bipolar disorder, worse prognosis with schizophrenia. Why it matters, lifelong meds with probably both conditions, but you don't necessarily need the antipsychotics all the time. In bipolar disorder, you just need to treat the mood symptoms so they don't come back on. You can use, again, the newer antipsychotics that are mood stabilizing as well, and there's various reasons for why you might want to that we'll talk about in the next lecture about treatment. But again, the big thing in the making the differential is the prognosis. And schizoaffective, being a blend of the two, often also has a blended prognosis, is that you can get intermittent phases of psychosis in schizoaffective where someone sort of can come back to baseline, but they don't seem often to fully recover the way that bipolar do. Individuals with bipolar do. So they don't have 100% recovery, but much better than you would say see with pure schizophrenia. Schizoaffective is quite variable, and again, much less is known about it because it is rare, and we may get the diagnosis wrong quite often because of drug and medical issues that come and go. Now, what about the other ones that I mentioned kind of at the beginning? So again, most of these psychotic symptoms are characterized by alterations in perception and reality, but sometimes you just have the delusions. And if they're overtly bizarre, we consider that to be sort of a symptom of schizophrenia, the belief that the aliens are out there, that they're energy weapons beaming into my head. But sometimes you get these things that almost overlap with personality in that regard, that you get someone who has a persistent delusion, say, that is not bizarre in that regard. The CIA is after me. Okay, that is possible. The CIA could be after you, but we've investigated, and that's clearly not true. There's no reason why you would believe that. You're not on any terrorist watch lists or whatever. Sometimes the delusions do turn out to be true, by the way. I had somebody who was convinced they were followed by the Secret Service, and it turned out, well, they threatened the president, so yes, they were followed by the Secret Service. But these non-bizarre delusions, if they exist by themselves, are called delusional disorder, and they have sort of an overlap with schizophrenia, but probably are biochemically distinct in that they do not respond very well to antipsychotic medications. Also in the differential, I said there are parts of personality. Some people just run odd beliefs. You know, all these conspiracy theories that are on the internet, QAnon, the truthers, all sort of things that just seem a little odd. And or people that we all know who are just overtly weird, who seem to be involved in, very faddish sort of beliefs as a whole. And that can be personality and not indicative of a true psychosis. When they have the presence of things that really shouldn't be there, these sort of odd behaviors and beliefs, we call that schizotypal personality disorder. When they have what more look like the negative symptoms of schizophrenia, the things that are missing that you would expect in a person where they seem very flat, not to be able to engage emotionally with people, we call that schizoid personality. So some people like that just like to live in a closet, almost look autistic in some ways, but without the other characteristics of autism. I should mention that autism sometimes itself does come with psychotic features. With that one, you should be able to diagnose much more easily because autism starts very early in childhood, and all these other conditions are going to start usually in early adulthood. For men, usually in their late teens through their 20s, for women through their mid-20s to their 30s. Bipolar disorder can occur somewhat later, but again, if you get to be over 40 and see these conditions, you really have to suspect something else. We used to think that schizophrenia could not exist over the age of 45, period, or could not start over the age of 45, because by definition we called it dementia praecox, the dementia of the young, right? And we thought it was something else. We now know that in rare instances it can, but it's very unusual to start later in life, but it's also not going to have existed all the way from early childhood, the way that an autistic spectrum disorder might exist in that regard. But again, I was talking about personalities, and someone can have this very flat personality that looks kind of like the negative aspects of schizophrenia, and we call that schizoid. You have the sort of just bizarre, odd habits, but again, not truly psychotic, and that's schizotypal. And again, that's not things that we really treat so much as it's just a differential. It's just another way of saying that this is an unusual individual, but not somebody who we think is truly biochemically psychotic. The third personality that could fit into that, by the way, is paranoid. So if you ever saw the Caine Mutiny, Captain Queeg, sort of always assuming that everybody else was acting against him in every regard. And again, paranoia can be a symptom of schizophrenia, but if it exists by itself, and that person has always kind of been that way, it may be an aspect of personality, and none of those things would we medicate. And sorry, brief interruption there for a patient, but we're talking about personality styles and how those are not necessarily conditions we would medicate. The other personality style that should be mentioned here is borderline personality, which is actually a condition we do end up treating mostly with therapy, although medications can be effective. It's going to be covered in the personality talks. It's covered a little bit more in bipolar. The reason it is relevant here, as the name implies, it borders on a lot of other conditions. It used to be defined, actually, back when we classified things into psychoses and neuroses, that it was considered on the edge there. It looks a lot like bipolar disorder in a lot of conditions. There are more subtle differences. Usually comes from a place of trauma. You usually see very rapid alterations in mood, as opposed not over weeks but over minutes. But you can get what are called pseudo-psychotic or dissociative symptoms with this, where a person does lose touch with reality but really under stress. So while we're talking about the issues of what is considered not true psychosis, there are a couple of other phenomena that can just seem strange, and we don't know really what to make of them, but we are clear that they do not seem to develop into schizophrenia. And there are some certain, quote, hallucinations that people experience that that are quite common, and again, maybe you experience them, but it doesn't mean that you're going to develop schizophrenia or bipolar disorder. One of those is hearing your name called. I've been walking down a hallway and was sure that somebody called your name. It happens. We're not exactly sure why. Phantom music, or now sort of phantom cell phone or pager syndrome, where you sort of a song gets stuck in your head, or you feel like your phone is going off. You think that happened, but I guess we hallucinated that. But again, it doesn't mean that people are going to be developing schizophrenia. Probably one of the most unusual, in my view, there are culture-bound syndromes. And so say within Native American communities, some of them, or Aboriginal communities, it's very common to think of people communing with the dead, with spirits in that regard, and it doesn't mean that they have schizophrenia. There's a whole section in DSM in regards to culture-bound syndromes from different cultures. In the West, however, this also has its parallels, that people will often, after the passing of a loved one, report that they saw or met with the loved one after that passing. And again, they never develop any other signs of primary psychosis. So, I don't personally believe in ghosts, but nevertheless, people seeing ghosts does not mean that they are psychotic. Another couple of interesting ones, dreams sometimes kind of blur into wakefulness. These are called hypnagogic hallucinations if it happens as you're going to sleep, or hypnopompic, as in like pop-awake hallucinations if they occur as you're waking up. It can be associated with other conditions, like it occurs in narcolepsy, but just extreme sleep deprivation, as I mentioned in sort of the delirium section, can cause certain types of hallucinations, and these are all considered normal phenomena. As with all DSM diagnoses, it really has to impair your ability to function in society in order to be considered a disorder at all. It's hard to imagine a version of schizophrenia in which a person wasn't impaired. There are some very successful versions of individuals with schizophrenia, John Nash probably being the most famous, the person who the book A Beautiful Mind was based on. But it's still, there's a lot of reality testing. Even he had a lot of impairments despite his success. So we do want to rule out these normal things. But again, to quickly summarize, if you've started after an ER clearance, someone has persistent psychotic symptoms, they have to last really at least 24 hours for us to consider any sort of lasting primary psychotic disorder. We're mostly going to be splitting those into the ones that eventually lead to schizophrenia with sort of staged diagnoses depending on how sure we are, brief psychosis leading to schizophreniform, leading to schizophrenia, but also the possibility of bipolar psychosis with psychosis occurring in the ups or down, major depressive disorder with psychotic features occurring with people just have profound depression and get psychotic there. There are some other zebras, delusional disorder, where again it's just fixed, non-bizarre delusions that appear later in life, don't appear to be part of personality, but lots of other aspects of personality. There are again some other zebras, some fun things like folie à deux, or the shared psychotic disorder, where one individual who seems to have a primary psychosis imparts those beliefs on someone else. Like they're convinced that they hear the voices, and they manage to sort of talk other people into believing that those voices are real too. The Salem witch trials were thought to be part of this sort of on a mass scale, where a couple of people probably with true psychosis or maybe secondary gain managed to convince a lot of people of some rather bizarre beliefs. So there are some other things out there, if you're digging in more into the depths of psychiatry, but at this stage, you're pretty much ready to start treating our major conditions of schizophrenia, bipolar disorder, and along the way, even brief psychotic disorder. So in the next talk, we're going to talk about antipsychotic medications, the antipsychotic revolution, how antipsychotics are one of the major changes in medicine that went along with hygiene, vaccines, antibiotics, and then antipsychotics were probably the biggest changes in the history of modern medicine. Of course, as we go along, there are more topics of psychiatry, more issues in other areas of science and learning. So I hope you continue to listen, subscribe, check in, and please comment, like, subscribe, do all the good things you always do on YouTube, and tell me how we can make this better. Thanks so much, and good day.